Hello, everybody. Welcome, welcome, welcome. Tonight, I'm bringing you Dr. Lincy Jojan, lead nurse practitioner at NorthShore University HealthSystem, PhD, and expert on shared decision making with kidney patients. Dr. Jojan is a nurse practitioner. The primary role of nurse practitioners is to monitor patient health, provide medical care, and serve as a primary care provider. Dr. Jojan's goal is to provide comprehensive health care to the adult population, identifying their needs and plan intervention that best meets the defined problem with emphasis on health promotion and disease prevention. Dr. Jojan began her academic career at St. John's College Medical College and Hospital in Bangalore, India, where she achieved her BS in nursing with honors. After arriving in the United States, she continued her education at Malloy University, Rockville Center, New York, as an adult health nurse practitioner. She is currently working as lead nurse practitioner in the Department of Medicine at NorthShore University HealthSystem, where she assesses, diagnoses, interprets radiological and lab findings, and prescribes treatment for acutely ill patients. She also precepts or directs MPs and PA students and new hires to the health system. She followed her dreams and achieved a PhD degree in January of 2023 with a GPA of 4.0, the highest degree required to work as an academic or in an academic research setting. Dr. Jojan is board certified as an adult nurse practitioner by the American Academy of Nurse Practitioner Certification. She is a co-author of a manuscript assessing practices, beliefs, and attitudes about palliative care among people with CF, their caregivers, and clinicians. The results of a content analysis that has been published in the Journal of Palliative Medicine in 2020. Her experiences as an intern with the Feinstein Institute for Medical Research fostered her love for decision science related to acute patient care and studying underrepresented populations. Her PhD interdisciplinary research dissertation focuses on enhancing the patient experience in shared decision making and improving the quality of care for individuals with end-stage renal disease. Dr. Jojan hopes to disseminate the findings in her study through publication, podcast, and through clinical practice. Tonight, we are going to discuss her thesis and work in shared decision-making with kidney patients. Please give a warm welcome to Dr. Lincy Jojan. Doctor, how are you tonight?
I'm pretty good. Thank you, Mr. Myers, for a great introduction, also for having me for today's podcast.
Okay. Let's talk a little bit. There we go. Let's talk a little bit about where you grew up, your education, and your employment experiences.
Yes, thank you. So I grew up in Bangalore, India. I started my nursing career from India after obtaining my bachelor's degree from St. John's Medical College, Bangalore, India. I had the experience of working as a pediatric renal transplant nurse for 2 years, as well as working as a lecturer at the College of Nursing for 2 years before arriving in the United States. I came to the US with a green card a decade ago after being hired by one of the hospitals in New York. I longed to practice nursing in a country where RNs earn respect as a nurse, higher income, better job satisfaction, and have an access to world-class healthcare resources. So after arriving to US, initially started working as an RN for a few years, and I wanted to advance my career and become a nurse practitioner. That was my dream. So as you know, now I'm a nurse practitioner. I'm prepared at the master's level. The educational programs are designed to make a graduate eligible for certification as a nurse practitioner in a specific area. So there are areas such as family nurse practitioner, adult health nurse practitioners, pediatric, mental health, psych, women's health. So I'm certified as a adult nurse practitioner from the American Academy of Nurse Practitioners, and I'm currently working as a lead nurse practitioner in a tertiary level 1 trauma center. It is NorthShore University Hospital in New York. So while practicing as an NP, I went ahead to earn my PhD degree, and I have the educational credential as a doctorate, similar to that given to any other profession. And eventually, I will also be working as an adjunct professor for graduate studies at one of the universities in New York. So that's pretty much about me.
Okay. You're a nurse practitioner. Can you please explain what an MP is?
Okay, so the most significant clinical role for a nurse practitioner relates to their professional efficacy and autonomy in practice. So they can diagnose, treat, prescribe medication, order diagnostic testing, and refer patients to other healthcare professionals and specialties. So nurse practitioners engage in evidence-based practice, and they bring a framework of prevention, early intervention, patient family health education into their work. In the United States and other countries, nurse practitioner needs to have a license to practice. And in United States, most such licenses are granted and supervised by the state you are practicing in. So the American Association of Nurse Practitioners defines a standard of practice for nurse practitioners, and they update or they revise them periodically. So when we look at the history of nurse practitioner, the nurse practitioner movement began in the United States in the mid 1960s with the preparation of pediatric nurse practitioner at the University of Colorado. Initially, the profession was developed in response to a shortage of physicians, especially in the rural areas where healthcare access was limited. Over time, the states other than Colorado began nurse practitioner training program, and the role of NPs in the healthcare greatly expanded. Today, nurse practitioners are integral to all kind of practices, including those located in underserved, rural, and inner city areas, and in private collaborations and independent practice, and also in hospitals and continuing cares and nursing home facilities. So many areas of United States have expanded the role of nurse practitioner. As of 2006, all 50 states have awarded nurse practitioners prescription authority. Many states also include controlled substance among the medication that the nurse practitioners can prescribe. And additionally, other countries such as UK, Canada, Australia, and New Zealand have embraced nurse practitioners. So, so that gives a brief history of how the nurse practitioner program actually evolved over time. And now we see nurse practitioner across the country, and we play a big role in healthcare.
Okay. What are your current duties and responsibilities as a nurse practitioner?
So I am a nurse practitioner, and I'm working in a tertiary hospital in a medicine department. So I work in a medicine department. I cover emergency room. I also cover it's a very large health system that I work for. So it's we have medicine. We cover medicine patients. We cover oncology patients, cardiology, nephrology, neurology. We collaborate with multiple different specialties. We refer patients. We work as a interdisciplinary team. We work with other specialties too. And when I'm working in the health system as a nurse practitioner, And also as a lead nurse practitioner, I am involved in assessing patients, doing physical assessment, collecting history and doing history and physical, diagnosing the patient and prescribing medication, ordering radiological and lab testings and interpreting those findings, and basically focusing on treatment, prevention, education, and follow-up care.
Okay. Shout out to all of our friends. We have quite a few people online that are listening to us tonight, Doc. And to my friend David, he's asking if there's an opportunity to ask questions. We're kind of on a schedule tonight, David, but if you put your question in the chat, if we have time, I'll make sure that Dr. Jojan sees it, okay? And we'll address it at that time. So yeah, you can ask questions. Just put them in the chat. What's the difference between a nurse practitioner and a physician?
Okay, that's a good question. Nurse practitioners perform health assessment, they diagnose, they order diagnostic and lab testing, prescribes medication, and offer treatment with a high level of autonomy and independence. They also take responsibility for monitoring patients' health and medical adherence, offer counseling, education, and also ensures continuity of care and manage hospital readmissions. So NP is also responsible for advanced consultation, collaboration with other practice, education, research, and leadership skills. So as I am a lead nurse practitioner, I'm involved in more of a leadership along with my practice. So they can funnel their practice towards specific demographic population. Also, we specialize in adult gerontology, acute care, mental health, women's health, and so on and so forth. So NPs are the first point of contact in the community, at a nursing home, geriatric health facilities, house calls, even at the clinics. But when we look at the difference between an MD or a DO or a medical doctor and a nurse practitioner, it comes with, when we look at the systemic review and looking at the education, the extent of education varies between the NPs and the medical doctor. But always nurse practitioner can choose further education. They can earn specialization in their areas. They can deepen their knowledge. They can become an advanced care provider by specializing in certain areas. Like you would have seen when you go to a hospital, you see NPs in neurosurgery, NPs in neurology, NPs in ortho, in specialty areas. So once you are becoming an NP, you can advance in these areas. But we technically don't do surgeries. So the extent of education between an MD and a nurse practitioner vary in those areas. But more or less, when we look at the research being done and based on the evidence and based on multiple literatures that I was reviewing to see before the podcast, just to see what exactly do we see any difference between an NP and a medical doctor, especially in primary care settings. The studies have concluded that the NPs are comparable or even better than the physicians at the primary care level, because we are looking at the outcome, the quality of life of the patient. We are looking into how many ER visits they have within a year, and also the satisfaction that the patient get when they are seen by an NP versus a physician, because NP is looking at a holistic care, looking into education, looking into counseling, looking at a person as a whole rather than just focusing on the disease itself. So definitely the quality of care provided by an NP versus an MD varies. But the extent of education could be a difference that we usually see. But then when it comes to primary care, we are almost better or equal to an MD in primary care settings.
Okay. Do you spend time or do you work with dietitians at all?
We work with dietitians, we work with case managers, we work with social worker, we work with physical therapists, occupational therapists, because we look at the patient as a whole. So we work in collaboration with all of them. So if we think that a person is diabetic and it's an uncontrolled diabetes, we are managing with medications, we are managing with insulin, but at the same time, we are seeing that patient would definitely help with the nutritional counseling. We involve nutritionists in us, managing teaching the patient based on what their preference and what their likes and dislikes are, which they are much more efficient in doing that. So we collaborate with them with nutrition. If somebody requires a physical therapy and how they can manage care at home, we involve physical therapists, and at the same time social worker if we see that patients are having financial issues, or if they are not able to we prescribe medication, but at the same time we also look into whether they can afford those medication. Are they able to pay for those medication, or do they have insurance coverage for those medical treatments? So we collaborate with case managers and social worker in those cases. So we look into the overall aspect, and even we look into the social conditions of the patient who is coming, and how we can help them even outside in the community itself.
Okay, let's talk for a minute about your study concerning palliative care. Can you please tell us what that study was all about and what conclusions you arrived at?
Okay, so my study, I actually, I was the second author for that particular study, and this study was done by the Feinstein Institute that I was working with, and it was an NIH-funded study. So study was to assess the practice, belief, and attitude about palliative care among people with cystic fibrosis, their caregivers and clinicians. So basically, we had 48 cystic fibrosis adult patients. We had 59 caregivers, and we had 229 providers who responded to this open-ended survey that we had distributed. So we wanted to see what is their attitude and beliefs towards involving palliative care once a patient is diagnosed with cystic fibrosis. So when a patient has cystic fibrosis, the treatment is lung transplant. And we know the life expectancy of these patients are also quite short. So the study findings, we see that the analysis showed variations within the group in defining palliative care for cystic fibrosis and how it should be delivered. Many respondents felt that the palliative care was underutilized in cystic fibrosis, and most of them saw palliative care as particularly important when considering lung transplant, when we have to manage the anxiety around transplant, and for the goals of care discussion. So some believed palliative care and lung transplant were mutually exclusive. So definitely palliative care should be involved. That was the results of the test, results of the analysis. The caregivers felt, the patients felt, and also the providers felt that the palliative care should be part of a discussion when it comes to cystic fibrosis.
Okay. Can you tell us what is the difference between palliative care and hospice or end-of-life care?
Sure. So when it comes to modern palliative care, it was developed from the hospice philosophy, which was founded by Cicely Saunders, and the aim was to improve the quality of life for patients with life-threatening illness, not just for cancer, but any life-threatening illness, symptom management by meeting the individual needs to prevent and provide relief of physical, psychosocial, spiritual suffering, and care of patients' families. So this aim was fundamental to all palliative care service, and it was Dr. Balfour-Mont who coined the term palliative care. This came around 1975 to describe his hospice program. It started in Canada, and it has since gained acceptance worldwide. So over the past few decades, we come across many different other terms: care of the dying, terminal care, end-of-life care, continuing care, holistic care, comprehensive care, comfort care, quality of life care. So, and more recently, we see supportive care. So there are different terms were coined after this, but homogeneously speaking, all three of these, like the hospice, the palliative care, the supportive care, it all focuses on improving the quality of life by addressing physical, emotional, spiritual needs and supporting their families. But if you look at chronologically speaking, hospice care is the earliest term, and supportive care is something which came recently, and palliative care is somewhere in between. So hospice care is limited to patients. It's not just, we think that hospice care is just limited to terminal illness, when you see that the prognosis of the patient is somewhere less than 6 months in United States. So then we talk about this supportive care, and but basically we are trying to focus on the quality of care. And the new terms started coining in only because people have this stigma associated with hospice. If we talk about hospice, it's all about, like, it is end of life, it is death, or somebody is going to die pretty soon. So it creates an anxiety among the patients, and also it creates an anxiety within the caregivers who are taking care of these patients. So basically, to minimize these anxiety with these patients and families, the new terminology started coming in. But it's all focusing on the quality of life. Rather than increasing the quantity of life, it's more focused on the quality of life, and also addressing what the patient wants. Basically giving them a complete holistic care. So that's where the difference in these terms are.
Okay. Let's talk a little bit about your experiences with kidney patients. Can you briefly describe what your experience is with people like me?
Okay. So I started my career when as an RN, working as a pediatric renal transplant. So I was a novice nurse, and I became the pediatric transplant nurse. And this was during the initial years when transplant was just coming up, when I was back in India. And I felt like at that time, it was all about live donors. We were not using any disease donor during the initial transplant phase, when it was just started in pediatric population specifically. So I was taking care of these transplant recipient and the donors. The donors were usually their parents or their grandparents, and they were very close to this child. So I was taking care of both the donor and the recipient. And within that the first 24 to 48 hours is very crucial for the transplant patient, and you're closely monitoring them. And when you start seeing rejections happening, and that was it was emotionally putting a lot of toll on me, because I did work with them for 2 years, and I decided when I came to United States, I didn't want to work with pediatric population anymore, and I wanted to focus on adult population. And that's how I ended up becoming an adult nurse practitioner, and to seeing patients 18 years and above. And so once I became a nurse practitioner, I started working with adult population who were acute or chronic kidney disease. Some who were just being diagnosed in the hospital, or some were already being diagnosed, and they were coming back to the hospital for other comorbidities like diabetes, uncontrolled diabetes or hypertension, or they were in the list for transplant and preparing them for transplantation, or some of them were post-transplant. They were coming back because now they're having issues because now they were non-compliant with their medications. As you know, after transplant, you have to be on these anti-rejection medications, and you have to be consistent with your, with your diet, with your exercise, with your hydration, and so on and so forth. But some of them, you have some of these patients who are non-compliant with these, and they ended up coming back to these hospital for, showing early signs of rejection. And so that's what I do nowadays, taking care of adult patients and seeing them pre and post transplant, and who are being listed in who are being initiated into dialysis, and looking at the difference of having patients who are in center for hemodialysis, and also some of them who are already on home peritoneal dialysis, and they're coming back because now they have peritonitis or some infection, or their peritoneal catheter is being dislodged and they're coming for replacement. So on and so forth. So mostly seeing adult patients.
Okay. In general, please explain what shared decision-making is with chronic kidney disease patients. Why is it significant and important to include patients in the decision-making process?
Yes. So shared decision making allows a clinician and patient to participate jointly in making a healthcare decision. So taking into account the benefits and harms of all the options and considering the patient's values, preference, and circumstances. Despite the potential for shared decision making to improve patient-centered outcome, the implementation of shared decision making in care has been limited because of the clinical factors. We see that limitations are both from the provider side and also from the patient side. On the provider side, some of the limitations are due to limited time, lack of applicability to the patient situation, poor communication skills. But when it comes to the patient factors, these include patient-provider power imbalance. Patients see that the physician or the provider is superior to me, and how will I be able to ask questions? How will I be able to express my concern? The provider has a better knowledge about my condition, so let him or her decide for me. And sometimes lack of health literacy, sometimes it's the denial about the health condition itself. Sometimes the patient doesn't understand what is going on with that, and they are so shared decision making is basically a conversation that happens between the patient and the provider to reach a choice that is best applicable based on their patient's values, preference, and also basically once you have a shared decision making that's been done, especially in CKD patients, any kind of situation, it can be in atrial fibrillation, it can be any particular kind of situation where you have multiple different treatment options when it is available, or when you're making a surgical options, or when you're making medication options or a diagnostic testing, in any aspects, you need to have a shared decision making. The patient should have a shared decision making with the clinician or with the provider. And also this, once you have a shared decision making, this will help to improve outcome and also to manage healthcare more effectively, and it will improve the patient's satisfaction, and we can minimize non-compliance with the patient, because some of the time, as when I have a discussion with these patients, and when I see, you see these frequent flyers coming to to the hospital within a year, and I ask them, why is that you are being non-compliant? Why you're missing your hemodialysis, or why you're not keeping a sterile technique in doing your handling your peritoneal catheter or things like that, they say that I never had what I wanted. This is against my will, my values. I don't have enough help. I don't have the services that I need. So many of the time, these decisions never happened, and that led to conflicting decision making. So in order to avoid all this, decision making is a key element.
Okay. Let's talk a little bit about your thesis, chronic kidney disease patients and experiences in the decision-making process. Can you tell us, how did you come up with this topic? Why did you choose this particular topic?
Yes, very interesting question. So to my knowledge, this could be the first study considering multiple individual characteristics that may affect the perception of the individual with CKD and their participation in shared decision-making analysis modality. As I said, when you have more than one treatment option available, definitely a shared decision-making is important, because now the patient is facing a scenario in their disease trajectory. You have multiple transplantation, dialysis, which is in-home hemodialysis, in-home peritoneal dialysis, in-center hemodialysis. So conservative care where you don't want any of these, but you're focusing only on the quality of life. So the study that I'm conducting, this is kind where was to look at individual characteristics and explain their relationship, such as with decisional self-efficacy, decisional conflict, and relationship with their participation in shared decision-making in the context of chronic kidney disease. So when it comes to decisional self-efficacy, which refers to the self-confidence or the belief in one's ability to make the decision. So focusing on, is the self-efficacy of the patient influence shared decision-making? If the person has an increased self-efficacy, they are able to make a better shared decision-making and have a better satisfaction that they have made. If they have a decreased self-efficacy, they are not able to make a shared decision-making, and the outcome is they have more decisional conflict, and there is less satisfaction with the decision-making. But what is decisional conflict? So this typically occurs when a patient is faced with difficult decision for which multiple reasonable, and when the patient, they are unsupported decision making for in their decision making process. So unfortunately, little research has reported on the factors which contributed to decisional conflict about dialysis modality. So ultimately, I did the literature review and I was going through different studies being done in shared decision making, and especially with kidney patients. I mean, shared decision making studies have been done with cancer patients, with prostate cancer, breast cancer, with atrial fibrillation population, and in settings. But when I started looking, because my interest and my passion is always been kidney patients, so I was looking at what are the studies being done on shared patients. There are a couple of studies done, not included the factors like decisional self-efficacy, decisional conflict, personal characteristics. So I felt like this study would be an important milestone in making. So that's how I ended up taking this particular topic.
Okay. You were kind enough to send me an abstract. Your abstract discusses the difficulties that patients face in choosing a modality for dialysis treatment. Can you talk to us a little bit? What did you mean by that? And does that include being advised upfront about the possibility of preemptive kidney transplant?
Yes. So patients are often uncertain as to which treatment choice was the best alternative for them. And many of them start experiencing decisional conflict. So this decisional conflict increases the likelihood of making a decision that is not based on patient's values or preference. And this results in an undesirable post-decisional consequence. So to make the best treatment decision possible, the clinician should about all the available treatment options, the risks and benefits of the treatment, and the importance of informed exploration of the patient's preference and values. So, due to lack of timely information about all these, valuable information about treatment alternatives, hemodialysis, and maybe and what is the best available option available to them, if these decisions are not happening at the right time, then this lead to decision conflict, and sometimes this creates a lot of anxiety in these patients. So avoid this. I feel that and patient ends up in crashing into dialysis. Or you probably would have seen in the hospitals, like the patient and ultimately they tell them you need to go into dialysis. But this, I always feel the progression of disease doesn't happen overnight. It takes a considerable period of time. So you had, when you, as a provider, when you are having these patients in your under your care, you have a considerable period of time where you could have started these discussion much earlier in the stage of disease. Like, CKD has 5 stages, and at what stage we could have had a timely intervention or a timely discussion. This could have prevented rushing into dialysis. We could have already spoken about preemptive transplant with these patients, and the patient could have enough time to have a discussion with the provider, discuss with the family, and to discuss the benefits and the risk and the other options of available, and come up with the best decision that would be applicable for the patient, rather than to rush dialysis when you enter emergency room.
Okay. David, she's going to answer your question in a couple of questions, so just be patient, okay? I noticed that you used patients' demographic characteristics. They were utilized in your study. Please describe for us the importance of using demographic characteristics in your study, and what were some of the experiences shared by the participants in the study regarding their shared decision-making process and concern for care and treatment? This gave you the ability to quantify, right?
Yes.
Okay. Can you please explain?
So definitely, it was looking into the characteristics of this population or the participants that I have included in the study was very important. So it is vital that we understand what drives these patients' motivation for participation in decision making and improving their ability in decision making awareness. So I included one of the important factor: sex, male or female, race, ethnicity, education qualification, and relationship status, whether they were single, married, partnered, or divorced. And coming to the findings of the study and what based on the narrative the patients had, because it was an open-ended survey, the participants could put, basically explain to me what exactly they felt during the decision-making process. So coming to the findings, the participants varied in their response on how and when they received selected treatment option information. Some received hands-on learning from a trained healthcare professionals in a classroom setting. Some participants were guided by the clinicians to explore websites, literatures, YouTube, and other social media to obtain information, and which was reported as stressful, as it is hard to trust what is on the internet and hard to process the gravity of the situation. Participants in the study gave most value to physicians and nurses as a source of information on kidney disease. None of the participants in the survey reported receiving health decision as an information report patient shared. And few participants felt a perceived lack of choice as the most common reason for selecting dialysis as a treatment option. They felt that the providers was not involved in decision making and they could not decide independently. 1/3 of the patients who had chosen dialysis reported feeling forced to make a decision whether the healthcare provider creates passivity and hinders the patient from making a decision autonomously. So the patients who thought they have been involved in the modality selection process were more likely to be satisfied, and those who were not involved in shared decision making definitely were going through decisional conflict. And most statement from the participants related to their perception of factors that influence them to make the current treatment choice, and they said mainly it was based on their convenience, how they could conserve the time during their busy schedule, giving them the confidence to select the treatment option that best suited for their lifestyle. In addition, those who received information information that they had received from the healthcare provider felt they were satisfied by the outcome of the decision when they felt that it was a shared decision making. But there was variation in the respondents' perception. Some patients felt they felt engaged in the dialogue with their clinician. They got verbal and written information about the treatment modalities. They were able to discuss all treatment options and they were able to rule out some of them which they felt was not applicable for them. On the other hand, there were participants who felt that the clinician decided the treatment option for them without allowing them to weigh in or educate them to make their own choices. Finally, others felt that the provider was not involved in the decision making and they had to decide on their own. A patient centered approach in decision making helps to clarify questions, it helps them to guide and reach at an optimal treatment choice, which is self selected between hemodialysis, peritoneal dialysis, dialysis, or kidney transplant. And such an intervention will help to reduce emotional stress by enhancing patient's sense of personal control over the difficult situation. So it is a very difficult situation for a patient when they are faced with this decision making, when you have multiple options available. And so unless you have a shared decision making, you are given an enough educational material, the concerns are being addressed by these providers, this only then it helps them make a best decision for them, and eventually it helps them as well as their family to feel supported by their provider. Unless otherwise, if you are chasing them away and telling them go find your own information, go through all these social media and get information, go to read your own literatures. Everybody is not literate enough to find these information, so we should always consider each individual as we should not be able to generalize everyone. Each individual has their own values and own preference and own limitations, and the education and the health literacy plays a key factor in this.
Okay. From your experience with kidney patients, what kind of decisions will they have to make concerning the modality of dialysis? And ideally, what kind of support are providers expected to provide to them?
Okay, very good question. So when we see a patient with CKD stage 4, which is defined as when a GFR is less than 30, and if that GFR is progressing over time, we need to start talking about dialysis and start preparing them for transplant or dialysis or palliative care as indicated. So we need to send them for ESRD. As we all know, ESRD is end stage renal deficiency, which is CKD stage 5. So the decision needs to happen, or discussion needs to happen when CKD stage 4 is defined as a GFR less than 30. As soon as that happens, we need to start having these shared decision making. Referral is given to GFR when it is reaching less than 30, When the GFR is reaching less than 20, we need to have a transplant discussion. At this point, the patient transplant can be transplanted if they have a live donor. If a person comes with a live donor and the GFR is less than 20, the transplant can happen, as early as a month, because you have to go through all those process transplant, in the go through all the blood work, echocardiogram, and then matching the roughly the transplant. That is called, we go for preemptive transplant. Preemptive transplant exactly means a transplant which is done prior to initiating or starting. So that can only happen if you have a live donor with you. If you don't have a donor, then you have to put yourself in the list for transplantation. So as I am the list for transplant in New York, the wait 8 years. So you can understand, you cannot wait if you're getting worsened and you are in the transplant list and it takes 7 to 8 years, you have to end up going into dialysis. So we recommend you can put your name in the list in other states which have a time. So that's called, you can list in your own state, start listing your name in other states as well. So as the disease is progressing, we also start discussing on different dialysis modalities or non-dialysis modalities. So coming to that is home hemodialysis, home peritoneal dialysis, or you have in-center hemodialysis. So patient gets educated on dialysis, how often you should have dialysis, how it is done, how is the access being created, and patient choose, and we also help them to choose. So we tell them what are the risks and benefits of hemodialysis, what are the risks and benefits of dialysis, the risk and benefits of having it at home, and the risk and benefits of having it. So we give them, but allow them to choose what is best for them. What they select may not be appropriate. So then with them, what is the best and why this is not the best. So these are an important factor. If somebody is having stenosis or a congestive heart failure and they are in high volume overload, so consider home hemodialysis rather in-center hemodialysis, or home hemodialysis or home peritoneal dialysis versus in-center hemodialysis, because it becomes harder for the patients to travel 3 times a week. And so we suggest them to go for home hemodialysis or home peritoneal dialysis. If we see that a person is non-compliant, there is safety issues at home, they have pets, we do not recommend home hemodialysis or PD because that becomes if you see that you have limited space and you have multiple people living in a smaller space, and then the chance of infection and becomes difficult. So if a person had multiple surgeries, the risk for additions is, so in those patients we don't recommend PD. The surgeon tell them not to PD because you are at a higher risk because of the abdominal surgeries that you have had. So in those patients, we ask them to consider home hemodialysis. Those almost daily treatment, but the luxury is you are able to do it at home instead of traveling. Again, job, lifestyle. If you are a person, your job may travel out more frequently, can make recommendations. If you are opting for PD and this is comfortable with you, make recommendation for cyclists carried, and bags, the dialysis bags can be delivered to your location, especially if you're considering PD. But we arrangement for if it is within the country. But traveling out of country, then we will suggest that you have to find your own generators, and you may have to pay out of pocket if you're traveling out of the country. So almost every patient should be considered for home first, unless there is a big contraindications for home. So the first discussion that we have with these patients who have to undergo dialysis, we talk to them about home hemodialysis or peritoneal dialysis. Again, coming to peritoneal dialysis, you have the option of continuous ambulatory peritoneal dialysis, which is normally done. You have to connect the bag, remove the bag. This is you require hands-on. But you also have the option of automated peritoneal dialysis, which is using the cycler. You go to work, you come home, you connect yourself with to the cycler time, and then you fill in you and then you drain the fluid. So the cycler does it for you. So and in the morning you just have to drain it yourself. So the cycler is continuously doing inflow and outflow. As you know, that in-center hemodialysis is 3 times a week, and it can be burdensome for the patient. The commute could be difficult. It's a long treatment procedure. The dialysis itself takes like 3 to 3.5 hours for filtration and removal of fluid. So it takes a big chunk of your time. And also with hemodialysis, you have to get an access. You create an AV fistula. So the fistula takes 4 to 6 weeks to mature. So you have to allow that to mature, and meantime you have a permacath, which is probably see a thing sticking out from the neck. That's the permacath. So the dialysis is done till the fistula is matured, and once the fistula is matured, then they remove the permacath and they start utilizing the AV fistula for the hemodialysis. But when you have to undergo an urgent PD catheter and a PD dialysis, usually they say that once the PD is inserted into your belly, you have to give a time of at least 2 weeks once for the PD to be initiated. But if it's an urgent PD and if they put a catheter in your belly and they're planning to start the PD within a day or so, the chance of developing a hernia is much more higher. So that's why we tell the patients you have to lay supine, you have to lay flat in the bed, and they start very slowly. But technically, you are supposed to wait for 2 weeks once the PD catheter is inserted for the PD to go. And also, if the patient is having PD, dialysis, peritoneal dialysis, we tell them you have to have a regular bowel movement. If you don't have a regular bowel movement, you have to be on some form of diuretic or bowel softener, because if you're constipated, this PD catheter can be dislodged or can leave the space. It should be in the pelvic cavity. Instead, if it starts moving up, then the drain is not happening sufficiently, and the toxins are not being able to be removed. So that's another key that we have to look into. But the studies have shown when we look at the life expectancy, patients between peritoneal dialysis, patients who are on peritoneal dialysis, and patients on hemodialysis, studies have shown that there is a better survival advantage to patients who are on PD in the first 3 years of initiation. After that, it's pretty much equal. So why is the life expectancy better in the first 3 years? It is seen that when the patients have a better residual renal function, like when you see that the patient is still able to make urine, it's a very important. So if the patient is still able to make urine, that means the clearance is still happening. The kidney is still functioning a bit, and it is helping to remove the toxin. So that helps the patient to get a better survival in the first. That's why we tell them renal patients who are going through renal failure to avoid anything that is toxic to your kidney, avoid NSAIDs like Motrin, Advil, those kind of medications, avoid going through CAT scans with contrast. Try to avoid any CAT scan which involves contrast, because contrast could be is a toxin to your kidneys. So you have to make sure those things have to be taken care of. And we have to preserve the kidney function. So as long as that's a good sign. And once your urine increasing and decreasing, then we have to do more aggressive form of dialysis. So the dialysis prescription becomes heavier and heavier. So rather than being gentle on dialysis, the provider eventually start becoming more aggressive on dialysis, because your kidneys are not functioning and the kidneys are not able to remove enough toxin. So and also the studies have shown which population does better on peritoneal dialysis. And for some reason, I'm not sure why, but studies have shown that in younger population, in females and non-females do better. Does not mean others.
Okay. Doctor, can you please talk to us about the results of your studies and what recommendations you've made?
Okay. So the result of my study found that there was a considerable inconsistency in providing educational material to these patients. The study revealed a greater understanding about how patients with CKD approach decision making when their illness have reached a point that requires treatment, and when more than one treatment option exists. So the findings contributed to the understanding that with the goal of increasing the patient involvement in determining the goals of care and the treatment choice, providers must approach these patients' critical decision point in their illness trajectory with openness of sharing in the plan of care, provide individualized care that incorporates patient goals and preference while setting and maintaining best practice with the quality and safety, keeping in mind the quality and safety of the patients. So definitely CKD patients at the stage is a crucial time. Needs to be initiated and discussed with the patient.
Okay. Do you have any future plans in your work that you can discuss with us tonight?
Yes. With my study is to develop a decisional aid. That with the survey that I did and from the narratives that I obtained from the patient, none of them discussed about decisional aid. So decisional aid is something that I would like to develop, focusing on the options that best fit into patient's life, talking about preemptive transplant, hemodialysis, peritoneal dialysis, home or in-center, conservative care or palliative care. So that would be my future project, or my future research would be focusing more on developing a decisional aid and addressing all the positive and negative option and guiding them in a decision making based on their literacy and based on cognitive needs.
Okay. Do you have any final statements that you wish to make tonight to our audience concerning shared decision making with CKD patients?
Yes. So to conclude, that early initiation of decision making is a paramount. Decision making dynamic point at time. Approach to shared decision making will help to achieve our goal to collaboratively decide with patient professional on a tray that best fits for their patient and consider.
Okay. All right. Well, that's our show for tonight. Doctor, I thank you for taking time to come on with us and discuss these issues. Just a great educational experience for myself and our audience. And of course, we want to give a big thanks and a shout out to our good friend, Kent Bressler from Kidney Solutions. I understand that he was helping you recruit patients for the study, and we want to make sure that we respect and honor Kent for his hard contribution to this matter. So that's going to end our broadcast for tonight, Dr. Jojan, and I just want to again say thank you. Geez, what a terrific raising of awareness you did tonight. I'm so grateful that you came on and spoke to us, and just a wonderful broadcast. Just wonderful. You did a terrific job. Thank you so very much.
Thank you so much, Mr. Myers, and to you and Mr. Kent, and the amount of work that you do for patients, and for having me. I mean, I'm really humbled by everything that you have done. And I'm grateful that I was able to be part of your Kidney Solutions and able to speak up on kidney, with my education and my experience that I have with this, with kidney patients, and what we can do for them. And that's and kidney encouraged me throughout my life as a nurse practitioner, and now as a PhD prepared NP. So I'm grateful to be in your podcast today.
No, I appreciate that very much. And to our friends out there, thank you so much for watching. We're back next week. We're going to talk about Gitterman's disease and PKD. I have a friend that is suffering from both at the same time, and treatment is not going well. So she is concerned about making a final statement, and I want to give my friend Stephanie Mosher a chance to do that. So I will see you next week. I appreciate you taking time. Dr. Jojan, thank you so much. Just terrific broadcast. I really appreciate it.
Thank you.
You guys take care, and I'll see you next week. Bye-bye for now.
Bye.